All right, let's talk spinal surgery coding. If you're a medical coding student and you're staring at that nervous system chapter in your textbook, feeling a little overwhelmed, well, you're in exactly the right place. Today, we're going to crack the code on a really specific set of procedures that you absolutely have to know for your exams. Let's dive in. So, here's our game plan. First, we're going to get to know the codes themselves, the absolute basics. Then, we'll tackle a scenario you'll see all the time, co-surgeons. After that, we're going to zoom in on a term that has a super specific definition in coding. We'll make sure you understand the number one most important distinction, anterior versus posterior. And then I'll wrap it all up for you with a cheat sheet you can take with you. So let's kick things off with the very first question you should always ask yourself when you're looking at a surgeon's op report. It's this: how did the surgeon get to the spine? Seriously, the answer to that one simple question is the key that unlocks everything else. Okay, first up, let's focus on one specific way in. This is where we build that solid foundation for the CPT code series 63075 all the way through 63091. And here it is, the first, biggest, most non-negotiable rule of this entire code set. Every single one of these codes, from 63075 to 63091, is only for procedure done from the front, that's the anterior side, of the spine. It could also be from the front and the side, which we call anterolateral. If that op report says the surgeon came in from the back, you're in the wrong neighborhood, the wrong code family entirely. Simple as that. So what kind of surgery are we even talking about here? Well, these are called extradural decompressions. All that really means is the surgeon is doing an open procedure where they can directly see the spine. They're looking right at it with their own eyes to relieve pressure. So think of it this way. This is not some tiny little keyhole surgery done with a scope. It's open and it's from the front. All right, let's move on and build on that. We're going to tackle a situation that trips up a ton of new coders, co-surgeons. It's all about getting a handle on modifier 62. So, when can you actually use modifier 62? Think of it as a 4-box checklist. First, you need 2 surgeons. And, this is the important part, both of them have to be acting as primary surgeons. Second, they can't just be helping each other out. They each have to perform a distinct, separate piece of the surgery. Third, you've got to see in the documentation exactly what each of them did. And finally, if all those boxes are checked, both surgeons add modifier 62 to the procedure code. Now, pay close attention here because this is a classic exam-style question. For the main primary procedure codes, yeah, modifier 62 is totally fair game. But what about the add-on codes for any extra work? Well, the rule here is just pure logic. You can only use modifier 62 on an add-on code if both surgeons were still working together as primary surgeons during that extra step. If only one of them did that part, then only they report it. No modifier needed. That's a huge distinction. All right, let's get even more specific. Into the real nitty-gritty. One of the procedures in this series is a corpectomy, which is just removing part of the vertebral body. But the codes almost always say partial corpectomy. And in the world of CPT coding, partial has a very, very strict definition. To master this, you only need to burn one number into your brain. Just one. And that number is 2. Why 2? Because there are 2 different rules, 2 totally different thresholds that you have to know, and it all depends on where in the spine the surgery is happening. And this slide lays it out perfectly. For the cervical spine, that's the neck, the surgeon has to remove at least 1/2 of the vertebral body. But for the thoracic and lower back, the mid and lower back, they only need to remove at least 1/3. These fractions are not suggestions. They are absolute rules. You've just got to memorize them. And here's why this is so important. If the surgeon's report says they removed, say, 40% of a cervical vertebral body, guess what? It doesn't meet that 1/2 threshold. So for coding purposes, it doesn't count. You cannot use the partial corpectomy code. This is an absolute make or break detail. Okay, let's zoom back out. We've been deep in the details of these anterior codes, but how do they fit into the bigger universe of spinal surgery coding? This is all about picking the right neighborhood of codes right from the very start. And this brings us right back to our golden rule. It all comes down to the primary surgical approach. Before you even think about cracking open your CPT book, you have to find the answer in that op report. Was the main part of this surgery done from the front, or was it done from the back? This slide makes it crystal clear. If that approach is anterior or anterolateral, you are living in the 63075 to 63091 code series. That's our world today. But If the approach is posterior, from the back, you have to use a completely different family of codes, 63001 to 63053. Mixing these two up is one of the easiest and biggest mistakes you can make. Okay, deep breath. We have covered a lot of ground. So now let's boil it all down into the absolute must-know points. This is your study guide, your cheat sheet for acing that test and for being a rock star coder from day one. Here we is. Number 1, approach is everything. Anterior means you're in the 630-75 series. Posterior means you're in a different world. 2, master modifier 62 for co-surgeons. 3, know your fractions. 1/2 for the neck, 1/3 for the rest of the back. And 4, don't forget, these are open procedures with direct visualization. If you can lock in these 4 things, you are in fantastic shape. And there you have it. You have just laid a super solid foundation for coding anterior spinal decompressions. I know this is a complex area, but you should feel really confident in what you've just learned. And with this knowledge locked in, the only question left is, are you ready to tackle the posterior approach? Yeah, after this, I think you absolutely are.